Hemolytic and ghost cell glaucoma. Hemolytic glaucoma, ghost cell glaucoma, or both may develop after a vitreous hemorrhage. In hemolytic glaucoma, hemoglobin-laden macrophages block the trabecular meshwork. Red-tinged cells can be seen floating in the anterior chamber, and the trabecular meshwork may appear reddish-brown. In ghost cell glaucoma, degenerated RBCs, ghost cells, obstruct the trabecular meshwork. Ghost cells are small, khaki-colored RBCs that have lost their intracellular hemoglobin, Fig 8-16. Because they are less pliable than normal RBCs, they obstruct the trabecular meshwork and cause elevated IOP. RBCs degenerate within 1 to 3 months after a vitreous hemorrhage. They gain access to the anterior chamber through a disrupted hyaloid phase, which can occur spontaneously or as a result of trauma or previous surgery, e.g., pars plana vitrectomy, cataract extraction, capsulotomy. Patients with ghost cell glaucoma typically present with elevated IOP and a history of or current vitreous hemorrhage from trauma, surgery, or pre-existing retinal disease. The IOP may be markedly elevated, with accompanying corneal edema. The anterior chamber may contain degenerated RBCs. The cellular reaction is often out of proportion to the aqueous flare, and the conjunctiva tends not to be inflamed unless the IOP is markedly elevated. On gonioscopy, the angle appears normal except for POS-CBLE layering of ghost cells in the Figure 8-16. Ghost cell glaucoma, the classic appearance of ghost cells in the anterior chamber. These small, khaki-colored cells can become layered, as occurs in a hyphoma or hypopion. Inferior angle. A long-standing vitreous hemorrhage may be present, with characteristic khaki coloration and clumps of extracellular pigmentation from degenerated hemoglobin. In these conditions, IOP typically normalizes once the hemorrhage has cleared. Medical therapy with aqueous suppressants is the preferred initial approach. If medical therapy fails to control the IOP, some patients may require anterior chamber irrigation, pars plana vitrectomy, and/or incisional glaucoma surgery. When a collection of RBCs or ghost cells is present in the vitreous, a pars plana vitrectomy is likely necessary for IOP control.